Okay, so intumescent cataract, that's another fascinating area. And since I told you about my first case when I was a fellow, I decided that this kind of cases should take another way. So cataract in Latino is waterfall, and intumescence means sudden swelling after exposure to heat. Now, I don't know what makes the lens heat up in the eye, but it swells suddenly. It is a stage that is often overlooked. It's fortunately not very common, and it is one of the stages of maturing cortical cataract. If you start to stage cortical cataract, the first one is incipient immature cataract. And what's unique about cortical cataract is these wedges that you see, these like triangular pizza pie appearance in the lens. The black ones are the water clefts, and the yellow ones are the cortical spokes. And this, with time, starts to reduce in size until it becomes all white. And in intumescent cataract, you still see some wedges, but once it matures, these wedges are absent. Now, you need to know how to differentiate between them, because there is a big difference in surgery between an intumescent cataract and a Morgagnian cataract. In a Morgagnian cataract, the lens is hard rock behind a white water fluid. And in its only mature intumescent cataract, there is no hardness at all behind. And the shrunken Morgagnian cataract is the one that you wish you wouldn't see, just like the one Dr. Jacob presented a while ago. Now, what is so special about intumescent cataract? If you look to the left, it can be caused either by senile, aging, idiopathic, or after severe trauma, or after severe inflammation. It is so unique because it can happen over days, over months, or over years. So you cannot anticipate how it will behave. If you see a patient with cortical cataract that is significant enough, do not give them long-term follow-up, because they might come with intumescence at any time. Once the fluid is filling the lens and the cortical material swells up, the tension in the bag and the IOL in the lens starts exerting everywhere. This will push out the lens to block the pupil and shallow the anterior chamber until the patient comes to you with high IOP. So, if you have a patient with this and you're sure they cannot come earlier, just give them a prophylactic PI to prevent pupillary block. You need to take a systematic history for them and ask the patient, why did the patient take too long to come to you for surgery? If it is, maybe this eye is amblyopic, maybe this eye, he never noticed that there was cataract in this, maybe he had trauma. And if the patient had traumatic intumescent cataract, you need to rule out other sequelae of trauma, especially optic neuropathy, maculopathy, retinal detachment, glaucoma, and whatever, because this can save a lot of turbulence and trouble during surgery and expansion. Every patient that goes with intumescent cataract should have a best corrected visual acuity if possible. I do for them the light projection, and with this I cover their good eye, and I ask them to tell me when do they see the light, and that should be a very bright light. And if they see the light, they have to tell me from which side it's coming. So I don't guide them. I don't tell them, do you see the light or you don't see the light? I ask them to tell me, when do you see the light? After this, if they do see the light, I change the color of the light, and I use these lenses from our optometrist, the green and blue, to make sure that the green and red, to tell me if the light color has changed. This helps a lot. Every intumescent cataract should have a baseline intraocular pressure and a B-scan. It is important to counsel your patient about the high-risk complications here, and they have to have a very signed consent, knowing what they are going to face in the future. Now, intraoperative tips. First of all, you have to have a very well-constructed wound. The wound should be, you can start with the side port first to inject the viscoelastic and the vision blue before doing your main port, because the chances of collapsing the HC is less. Your OVDs. Now, you have plenty of OVDs. I personally use a dispersive OVD, but if you go on the literature and see others, you can, a soft shell technique, a modified soft shell technique, and too many things are doing just like this multi-layered jello techniques, because they have effectiveness in reducing the post-op edema and the heat exerted on the cornea. In general, they put a dispersive part, like Discovisc, to coat the endothelium, and a cohesive one to coat the anterior capsule, which gives enough space for your rhexis to be done. And this is how, for your reference. Now, this is how you do the soft shell technique. You inject here a cohesive, and above is a dispersive. Now this is the surgeon injecting the dispersive part first, as he's expressing out the air bubble. And then he will come in with another cannula, another cohesive that is like Provisk, Protectalone 1.4%, just to push down the anterior capsule. And you can see how it went flat as he did this. Now, the intraoperative tip, the rate-limiting step is the capsulorhexis. If you do a proper capsulorhexis, everything else should go normal and regular. For capsulorhexis, you have a challenge of visualization, the behavior, and each one of them has tips. Visualization, you must stain it. Yesterday, we saw Dr. Akahushi staining his capsule with lissamine green. In Saudi Arabia and here, we are using vision blue. Some poor areas, they have none of these, and they can use fluorescein, which stains very poorly, and it's better if you have a cobalt blue light. Now, these capsules are so fragile that they do not behave normal. The moment you touch them with the pressure behind, they tear off, and they can extend, giving you an Argentinian flag appearance. To avoid this, after putting your soft shell technique or dispersive viscoelastic, make a slit cut by your cystotome. I'd like to do my cut 90 degrees perpendicular to my wound. So if my wound is at 3 o'clock position, I take my T shape. I make my wound T shape. I don't make it in continuation with my wound. I find this easier because if I go out of the anterior chamber and for any reason the AC collapses, it extends the way I'm going out. So I make it like a T shape with my wound. In other papers, I have seen them doing a star shape or a D shape rhexis to start. Never go into the theater for an intumescent cataract if you are not ready. It can be a catastrophe. Your vision blue, your dispersive viscoelastic, your multi-piece IOL, your vitrectomy, and your signed consent. If you have these, go ahead and take the risk. This is a beautiful video I borrowed from my colleague, Dr. Hafid Al-Falih, showing his technique in doing the intumescent cataract. He is so meticulous in staining the anterior capsule, as it should be. Then he injects the dispersive viscoelastic and milks the air bubble out. Now he uses the cystotome. And you can see, this is not edited, not fast-forwarded, how he does it. This is what I'm telling you, how we do your rhexis in a T shape with your wound. Slowly spiral circumferential rhexis along with repeated viscoelastic injection. And every time he loses visualization, he puts viscoelastic, aspirates it with a 27-gauge cannula. All this milky material is aspirated. Now, there are many other techniques where they can use synco aspiration, needle aspiration. All are correct. It depends on how comfortable you are, what is your comfortable zone. Now, he will continue to do the rhexis until he gets it smoothly extended nicely without any extensions to the equator. And with this, I will conclude Dr. Falih's video, which was a fascinating one. And I'll give you the video of Dr. Aik Ahmed, who has presented this also, but with the needle technique. Now he stains the capsule. And now, after putting the OVD, and I think this was a dispersive OVD, or Helon 5, if I'm not sure, and uses the needle. You can see now he will go direct into the anterior capsule and aspirate immediately. And this reduces the tension that is happening from the fluid. By this, Dr. Aik Ahmed then continues to do his rhexis smoothly and nicely. You can start small and enlarge it slowly until you get it right. The last video, and should be concluding my talk today, is done by me. Here, this is, I think you saw yesterday part of it, as I did my talk about iris hooks. And now here I did the same thing. I'm doing my gentle rhexis, but again I'm stubborn. I did not improve my visualization, so I had a very small rhexis. Now, the thing that stopped me from enlarging the rhexis later on was what you will see in a second. So now here, I have to continue. Rhexis is done smoothly, but it was slightly small. Now, as I'm injecting to see, you can see how the lens is rocking inside the bag. This was a Morgagnian cataract. And a Morgagnian cataract, I thought that if I will try to extend my rhexis, there is no support for my rhexis. It might extend by itself, or I will have a flail rhexis. So I decided to go in, take the challenge, and do a phaco-chop technique for my dense cataract. And here you can see I go around, but this second itself, as much as I go around, I tore the capsule out. Now that's a clumsy, immature technique, but it was not unexpected with this small rhexis. So I'm showing you this because there are two things I want to highlight. See how the rhexis is coming out of the wound? This is very dangerous. It's very dangerous, especially if you will go out. You see my right hand is holding the lens. I don't go out. I stop, I pause. And then I inject to make sure that my bag is full again. I will gently push away the anterior capsule from the wound and take the advantage of this small tear, relatively small tear. Of course, I assess it. This is a fluttering tear, which means it did not go to the equator. And by this, I managed to continue and place a sulcus IOL no, it was not in the sulcus, it went into the bag. And nicely placed in the bag because this was a limited extension. Thank you very much.